Before we begin, it's critical to state that I am not a licensed financial advisor, insurance agent, or medical professional. This presentation is for informational and educational purposes only. The information provided is not intended to be a substitute for professional financial, legal, or medical advice. Health insurance is complex and individual needs vary greatly, so please consult with a qualified and licensed professional to get advice tailored to your specific circumstances. You just got a letter in the mail. It's from the hospital. Your 7-year-old fell off the monkey bars at the park last month and broke his arm. You weren't that worried. You have good insurance through your job, the one you pay hundreds of dollars for every single month. You open the envelope, and your stomach drops. The bill is for $8,754. And below that, a line that says amount due from patient. It's the same number, $8,754. How is this possible? You have insurance. You pull out your wallet, look at that shiny plastic card with the logo of some big friendly-sounding company on it, and you feel a wave of confusion and anger. You've been paying them for years. What were you even paying for? If that scenario feels even remotely familiar, you are in exactly the right place. Because that confusion, that feeling of being cheated, is not your fault. The American health insurance system is a labyrinth, intentionally designed with confusing language, hidden clauses, and financial trapdoors. But here's the secret they don't want you to know. It can be understood. And understanding it is the single most powerful tool. You have to protect your family's health and your financial future. My promise to you in this video is simple. We are going to pull back the curtain. We will demystify family health insurance together. I'm going to give you a simple, clear framework that will transform you from a confused consumer into a confident navigator of your own healthcare. By the end of this, you will understand what you are paying for, how your plan actually works, and how to make the smartest possible choice for the people you love most. We are going to turn that confusion into confidence. So let's start with the absolute foundation. When you boil it all down, every family health insurance plan in America, whether it's an HMO, a PPO, a high-deductible plan, or anything else, revolves around 4 critical numbers. If you understand these 4 numbers, you understand 90% of how your plan works. These are your premium, your deductible, your copay or coinsurance, and your out-of-pocket maximum. Get these and you've got the keys to the kingdom. Let's start with the first and most familiar number, the premium. Think of your premium as your membership fee. It's the fixed amount of money you pay every single month just to be a member of the health insurance club. For most people with employer-sponsored insurance, this money is taken directly out of your paycheck before you even see it, which is why it can sometimes feel invisible. You pay this amount whether you go to the doctor 100 times or never at all. It's the price of admission. But here's the most common and costly mistake people make. They think that because they're paying this premium, their health care is now covered. That is completely wrong. Paying your premium doesn't mean your care is free. It just means you've unlocked the opportunity for the insurance company to help you pay for your care later. It gets you in the door, but you're not on the VIP list yet. To get that help, you first have to face the second, and arguably the most important number, the deductible. This is the big one. This is the number that created that shocking $8,000 bill for the broken arm. Your deductible is the amount of money you must pay out of your own pocket for your medical care before your insurance company starts to pay a single penny. Let me give you an analogy. Imagine your insurance coverage is a giant sleeping superhero. It's powerful, it can save you from financial ruin, but it's completely dormant. The deductible is the amount of money you have to spend to wake that superhero up. If your plan has a $5,000 deductible, you are on the hook for the first $5,000 of your medical bills for the year. The emergency room visit, the lab test, the specialist appointment, the surgery, it's all on you until you've personally spent $5,000. Only after you've hit that number does the superhero start to stir, wake up, and begin to help. Now this is where it gets uniquely complicated and critical for families. Because on a family plan, you don't just have one deductible. You have 2. You have an individual deductible and a family deductible. And the interplay between these two is what trips up millions of Americans every single year. The individual deductible applies to each person on the plan. Let's say your plan has a $3,000 individual deductible. This means that if one person, say your spouse, has a lot of medical expenses, once they personally have paid $3,000 for their own care, the insurance superhero wakes up just for them. Their costs for the rest of the year will now be shared with the insurance company. But, and this is crucial, the superhero is still sound asleep for you and for your kids. You are all still paying 100% out of pocket for your own care. That's where the second number, the family deductible, comes into play. The family deductible is usually double the individual one. So, in our example, it might be $6,000. This is the total amount that your family, as a unit, must spend on healthcare before the superhero wakes up for every single person on the plan at the same time. Let's walk through a real-world example because this is where the clarity happens. Imagine a family of 4, mom, dad, and 2 kids. Their plan has a $3,000 individual deductible and a $6,000 family deductible. In March, kid number 1 falls and breaks their arm. The total cost is $3,500. What happens? You pay the first $3,000 out of your pocket. That $3,000 satisfies that child's individual deductible. The superhero is now awake for kid number 1. The insurance company helps pay for the remaining $500 of that bill, and for any other care kid number 1 needs for the rest of the year. So far, your family has spent $3,000. Then, in June, dad gets a nasty case of pneumonia and needs a chest x-ray and medication. The bill is $1,000. Is it covered? No, because dad hasn't met his own $3,000 individual deductible, and the family as a whole has only spent $3,000 so far, not the $6,000 needed to meet the family deductible. So, you pay that $1,000 entirely out of your pocket. Now, your family's total spending for the year is up to $4,000. Finally, in September, mom needs a minor outpatient procedure that costs $2,000. What happens now? You pay that $2,000 out of pocket. But look what just happened. You spent $3,000 on kid number 1, $1,000 on dad, and now $2,000 on mom. Your family's total out-of-pocket spending for the year is now $6,000. You have officially met the family deductible. A giant alarm bell goes off, and the superhero is now wide awake and ready to fight for everyone in your family for the remainder of the year. Any eligible medical costs for mom, dad, or either of the kids from that point until December 31st will now be shared with the insurance company. Understanding this two-deductible system is the absolute key. A low individual deductible might seem great, but if your family deductible is sky-high, you could be facing thousands upon thousands in bills spread across different family members before your plan ever truly kicks in for everyone. You have to know both numbers. So, you've paid your premium to get in the door, and you've spent a mountain of cash to meet your deductible and wake the superhero. Does that mean everything is 100% free from now on? Not a chance. This is where the insurance company starts sharing the costs with you. And how they share it is defined by our next 2 critical numbers: the copay and the coinsurance. They sound similar, but they work in very different ways, and confusing them can cost you a fortune. That's what we're breaking down next. Let's start with the copay. Think of a copay as a cover charge. It's a fixed, flat fee you pay for a specific service, right at the front desk. You go to your primary care doctor for a checkup? That'll be a $30 copay, please. Need to see a specialist like a dermatologist? That might be a higher copay, maybe $60. Picking up a generic prescription? A $10 copay. The key words here are fixed and flat fee. You know the cost before you even walk in the door. It's predictable. It's simple. After you pay that fee, the insurance company generally picks up the rest of the bill for that specific visit. So if the doctor's office actually bills your insurance $150 for that checkup, you pay your $30, and your insurer pays the remaining $120. You don't have to worry about the total cost of the visit itself. You just pay your entry fee. Now, here's a critical detail that trips up millions of people. In most plans, the money you spend on copays does not count toward your deductible. Let me say that again because it's incredibly important. That $30 for the doctor, that $60 for the specialist, that $10 for the prescription, that money often vanishes into a separate bucket. It does not chip away at that big deductible number we talked about. It's just the cost of using your plan for routine things. This is where the system gets tricky, and where coinsurance comes into play. Coinsurance is a completely different beast. It isn't a flat fee. It's a percentage. It's the portion of the medical bill you're responsible for after you've paid your full deductible. Let's imagine your son, little Jimmy, wakes up with a terrible stomach ache. You take him to the doctor. You pay your $30 copay at the front desk. The doctor is concerned it might be appendicitis and sends you to the hospital for an emergency CT scan. This is where everything changes. That CT scan isn't a simple office visit. It's a major diagnostic procedure. It's not covered by a simple copay. This bill is going to be big. Let's say it's $2,000. And this is the kind of expense that does get applied to your family deductible. Let's stick with our example from before, where your family deductible is $5,000. Since it's early in the year, you haven't paid anything towards it yet. So when that $2,000 bill for the CT scan arrives, whose responsibility is it? It's yours. All of it. You have to pay that full $2,000 out of your own pocket. Your insurance doesn't pay a single penny yet, because you haven't satisfied your deductible. You've now paid $2,000 towards your $5,000 family deductible. You have $3,000 left to go. A week later, the results are in, and unfortunately, it is appendicitis. Jimmy needs surgery. He's admitted to the hospital, has the operation, and stays for 2 days to recover. The total bill for the surgery, the anesthesia, the hospital stay, the medications, it comes to a staggering $40,000. Now, you might be panicking, thinking you have to pay that whole amount. But you don't. You have insurance, and this is where it finally kicks in. First, you still have that remaining $3,000 on your deductible to cover. So you pay the next $3,000 of that hospital bill. Congratulations, you have now officially met your $5,000 family deductible for the year. You have unlocked the next level of your insurance plan. Coinsurance. Let's say your plan has an 80-20 coinsurance split. This is very common. It means that from this point forward, for the rest of the year, your insurance company will pay 80% of all covered medical bills, and you will pay 20%. So let's do the math on that $40,000 hospital bill. The first $5,000 was your deductible, $2,000 from the CT scan, $3,000 from the hospital bill itself. That leaves $35,000 remaining. Your insurance company will now pay 80% of that amount. 80% of $35,000 is $28,000. That's their share. Your share is the remaining 20%. 20% of $35,000 is $7,000. So, for this one medical event, your total out-of-pocket cost is your $5,000 deductible plus your $7,000 coinsurance payment. That's $12,000. It's a huge amount of money, absolutely, but it's a lot less than the full $42,000 in total bills you racked up. You can see the danger here. A copay is predictable. A 20% coinsurance on a bill that could be $10,000, $50,000, or even $500,000. That is terrifyingly unpredictable. A 20% share of a massive number is still a massive number. This is where the final and perhaps most important piece of the puzzle comes in. It's your plan's ultimate safety net. It's called the out-of-pocket maximum. The out-of-pocket maximum is the absolute most you will ever have to pay for your share of covered medical expenses in a single year. It's a cap, a ceiling. Once you hit this number, your insurance company pays 100% of everything for the rest of the year. You don't pay another dime in deductibles or coinsurance. Let's say your family's out-of-pocket maximum is $15,000. In Jimmy's surgery example, you've already paid $12,000, your $5,000 deductible plus $7,000 in coinsurance. You are now only $3,000 away from hitting your maximum for the year. If heaven forbid, another family member has a medical emergency that costs $10,000 a month later, you would only pay your 20% coinsurance on the first $15,000 of that bill. 20% of $15,000 is $3,000. Once you pay that, your total spending for the year has reached the $15,000 out-of-pocket maximum. You're done. The remaining $7,000 from that bill, the insurance company pays it. Any other medical bills for the rest of the year, the insurance company pays 100%. You just continue paying your monthly premiums and any small copays for routine doctor visits. This number, the out-of-pocket maximum, is the true measure of your financial risk in any given year. It's the worst-case scenario. When you're comparing plans, a lower deductible is nice, but a lower out-of-pocket maximum can be a financial lifesaver. It protects you from bankruptcy in the face of a true medical catastrophe. So let's recap the flow of money. First, for small routine services, you pay simple flat-fee copays. Second, for larger medical events, you pay 100% of the costs until you meet your deductible. Third, after your deductible is met, you enter the cost-sharing phase, paying a percentage of each bill, your coinsurance, while the insurance company pays the rest. And finally, once your total spending on the deductible and coinsurance adds up to your out-of-pocket maximum, you are off the hook. The insurance company takes over and pays 100% of your covered costs for the remainder of the year. Understanding this sequence is the key to understanding how your health plan actually functions. But all of these numbers, the deductible, the coinsurance, the out-of-pocket max, They all operate based on one huge unspoken assumption: that you are staying in-network. The moment you step outside your approved network of doctors and hospitals, this entire rulebook gets thrown out the window, and the financial consequences can be devastating. That's the critical difference between an in-network doctor and an out-of-network one, and it's what we need to break down next. Think of your health insurance plan's network as a private club. The insurance company has gone out and made special deals with a specific group of doctors, clinics, and hospitals. They've negotiated VIP pricing. To become a member of this club, a doctor agrees to accept a significantly lower payment for their services than what they would normally charge the general public. In exchange, the insurance company agrees to send its members, that's you, their way. So when you visit an in-network doctor, you're getting access to this exclusive pre-negotiated discount. This discount is the most important and most misunderstood part of how your insurance saves you money. It happens completely behind the scenes, before your deductible or copay ever even enter the picture. Let's imagine a scenario. Your daughter, Maya, is playing soccer and takes a nasty fall. Her wrist is swelling up, and you're pretty sure it's broken. You rush her to an urgent care clinic. The clinic takes an X-ray, confirms it's a simple fracture, and puts her arm in a cast. A few weeks later, you get the explanation of benefits from your insurer. It shows that the total amount the clinic billed for everything, the visit, the doctor's time, the X-ray, the cast materials, was $3,000. Your heart sinks. You haven't met your family deductible yet, so you're thinking you have to pay that full $3,000 out of your own pocket. But then you look closer at the document. Next to the amount billed, $3,000, there's another column labeled Plan Discount or Negotiated Rate. And in that column it says the discount is $2,000. The final allowed amount is only $1,000. What just happened? Because that urgent care clinic was in your insurance plan's network, they had a contract. They had already agreed, long before you ever walked in the door, that the acceptable price for that specific combination of services was $1,000, not $3,000. That extra $2,000? It essentially vanishes. The clinic is not allowed to charge you for it. This is a contractual write-off. It's the single biggest benefit of staying in network. Now, and only now, do your plan's rules kick in. Your deductible, your copays, your coinsurance, they are all applied to that much smaller, $1,000 allowed amount. So, if your family deductible is, say, for $1,000, you will be responsible for paying that $1,000. It goes towards your deductible. Once you've paid it, you'll have $3,000 left to meet for the year. But the crucial part is, you're paying $1,000, not the terrifying $3,000 the clinic originally billed. You save $2,000 without even lifting a finger, simply by walking into the right building. Now let's rewind the clock. Same injury, same scared daughter, same swollen wrist. But this time, in your panic, you drive to the urgent care clinic that's just a little bit closer. It looks new and professional, the sign is bright, but you don't stop to check if it's in your network. You just want to get Maya seen as quickly as possible. Unfortunately, this clinic does not have a contract with your insurance company. It is out of network. You have the exact same experience. They take an X-ray, they put on a cast, and they send you home. The clinic also bills a total of $3,000 for the services. They send that $3,000 bill to your insurance company. This time, the insurance company receives the bill and doesn't recognize the name of the clinic. They check their system. No contract, no deal, no VIP pricing. So what happens? Your insurance company isn't just going to pay whatever an out-of-network doctor decides to charge. Instead, they'll determine what they consider a usual, customary, and reasonable, or UCR, amount for those services in your geographic area. This UCR amount is a key concept. It's what the insurer thinks the service should have cost, and it is almost always far, far lower than what the out-of-network provider billed. Let's say your insurer decides the UCR for a broken wrist visit, X-ray, and cast is $800. Now, most plans have very different and much worse benefits for out-of-network care. You might have a completely separate, higher deductible for out-of-network services. And instead of your insurance covering 80% after the deductible, they might only cover 50%. So your insurer applies your out-of-network benefits to that $800 UCR amount. If you haven't met your out-of-network deductible, you might be on the hook for the full $800. Even if you have, and your insurance agrees to pay 50%, that means they send a check for $400 to the clinic. But here is the devastating difference. The clinic billed $3,000. Your insurance paid $400. What happens to the remaining $2,600? The clinic sends you a bill for it. This is called balance billing. And because there is no contract between that clinic and your insurance company, it is perfectly legal. The clinic is not required to write off that difference. They expect you to pay the balance of what the insurance didn't cover from their full, undiscounted price. So let's compare. Scenario 1 in network. Your total out-of-pocket cost was $1,000. Scenario 2 out of network. Your total out-of-pocket cost is $2,600. For the exact same broken wrist, the exact same treatment, the only difference was which door you walked through. This isn't an exaggeration. This is how people end up with shocking 5-figure medical bills for routine procedures. They unknowingly get treated by an out-of-network provider. Balance billing is the single greatest financial threat in the American healthcare system for people who have insurance. Staying in network is your shield against it. You might be wondering, why would any doctor choose to be out of network? Well, it's a business decision. Highly specialized surgeons in major cities, for example, might decide they have enough demand for their services that they don't need the steady stream of patients an insurance company provides. By staying out of network, they can set their own prices and charge whatever the market will bear, without being limited by an insurer's negotiated rates. For most standard doctors, hospitals, and labs, however, being in network is essential for survival. It's how they get the vast majority of their patients. The takeaway from all of this is simple, but it is the most important rule you will ever learn about using your health insurance. Unless it is a true life-threatening emergency, you must always verify that a provider is in your plan's network before you get care. Not just the hospital, but the specific doctor. Not just the surgeon, but the anesthesiologist too. Because here's another trap many people fall into. You can go to an in-network hospital for a planned surgery, only to find out later that the anesthesiologist who put you to sleep was an out-of-network contractor who just happened to be on duty that day. The hospital's bill is processed in network with the big discount. But then weeks later you get a separate shocking bill from the anesthesiologist for their full undiscounted rate, and you're on the hook for it. Congress recently passed a law called the No Surprises Act to protect patients from this specific situation in emergency rooms and for care at in-network hospitals. But the system is still full of gaps and gray areas. Your best defense is always to be proactive. So how do you do that? How do you reliably check who is in your network and who isn't? It sounds as easy as a quick Google search, but the reality is a minefield of outdated directories, confused receptionists, and misleading information. Getting this wrong is not an option, so we need to get the process right. Next, we'll walk through the step-by-step foolproof method for making sure you are always in network. So let's build that foolproof method. Think of it as your 3-point safety check, the pre-flight inspection you perform before your family's healthcare takes off. Getting this right is the single most powerful thing you can do to prevent a financially devastating surprise bill. We call it the triple check verification, and it starts not with a phone call but with your computer. Step 1 is the digital reconnaissance. You must begin at the source, your insurance company's official website. But here's the critical detail most people miss. Do not, under any circumstances, use the public-facing Find a Doctor tool on their homepage. That is a generic, often inaccurate marketing tool. You need to log in to your specific member portal. Once you are inside your account, you are looking at a provider directory that is supposed to be tailored to your exact plan. This is your starting point. Search for the doctor you're considering. Let's say you're looking for a pediatrician named Dr. Evelyn Reed. You'll type in her name and location. When her profile comes up, you're looking for a few key pieces of information. First, does she appear as in-network? Second, what is the name of the medical group or hospital system she's affiliated with? Sometimes a doctor is an independent practitioner, but more often they are part of a larger group, like Oakwood Pediatric Specialists or St. Jude's Medical Group. This is a vital piece of the puzzle. Finally, if you can find it, look for a number called the NPI, or National Provider Identifier. This is like a social security number for doctors. It's a unique 10-digit ID. Not all insurance portals show this, but if it's there, write it down. Once you have this page up, take a screenshot. Save it. Date it. This is your first piece of evidence. You've documented that on this specific date, your insurer's own system listed Dr. Reed as in network. This step alone is better than what most people do, but it is absolutely not enough. These online directories can be notoriously out of date. A doctor could have left the network 3 months ago, but the website hasn't been updated. Relying solely on this is like trusting a map from 1985 to navigate rush hour traffic today. It's a gamble. So we move to step 2. Step 2 is the human verification. Now you pick up the phone and call the doctor's office directly. But you are not going to ask the question everyone else asks. Do not call and say, "Hi, do you take Blue Cross insurance?" That is a useless question. The person answering the phone will almost always say yes, because they likely accept some form of Blue Cross, but they might not accept your specific plan. Remember, an insurance company like Blue Cross or United Healthcare might have dozens, even hundreds of different plans in one state. Some are PPOs, some are HMOs, some are marketplace plans, some are employer-sponsored. They are not all the same. Instead, you are going to use a very specific script. It goes like this. Hello. I'm calling to verify if Dr. Evelyn Reed is an in-network provider for my specific health insurance plan. My insurance company is Blue Cross, and my plan is the Blue Choice Preferred PPO Gold 300. You read the exact plan name right off your insurance card. Then you say, "Would you like my member ID number to confirm?" This changes the entire dynamic of the conversation. You've moved from a vague, general question to a precise, verifiable request. You're forcing them to look up your actual plan, not just give a lazy yes. When they confirm that the doctor is in network, you have 2 more crucial questions. First, can you please tell me the exact name of the medical group that you bill under for this plan? This confirms the information you found online. Second, and this is the pro-level move, could you also provide me with the tax ID number for that medical group? They may or may not give you the tax ID, but asking for it shows you're serious and often gets you to someone in the billing department who actually knows what they're talking about. The tax ID is the ultimate identifier for the practice. Now, before you hang up, you do one last thing. You ask for the name of the person you are speaking with. You write it down, along with the date and time of the call. This is your second piece of evidence. You now have a record of a specific employee at that office confirming your coverage on a specific date. We're getting closer, but we're still not done. Why? Because even the doctor's office can be wrong. Staff turnover is high, and the person you spoke with might be new, or they might have made a mistake. They have no financial liability if they give you bad information. You're the one who gets the bill. So we move to the final, most important step. Step 3 is the insurer confirmation. This is the one that truly counts. You are now going to call the ultimate source of truth, your insurance company. Use the member services number on the back of your insurance card. When you get a representative on the line, you are going to use all the intelligence you've gathered. Your script will sound like this. Hello. I am calling to confirm the network status for a provider before I schedule an appointment. My plan is the Blue Choice Preferred PPO Gold 300. Then you provide the details. The provider's name is Dr. Evelyn Reed. Her NPI number is. Give them the number if you have it. She is part of the Oakwood Pediatric Specialists Group, and their tax ID number is. Give them the number if you have it. You see what you've done? You've given them multiple, highly specific data points to cross-reference. You're not just asking about a name, you're asking about a specific provider, at a specific practice identified by unique government-issued numbers. You are making it almost impossible for them to give you ambiguous or incorrect information. After they put you on hold and run the check, they'll come back and say yes or no. If they say yes, you're not finished. You have one final golden ticket question to ask. Thank you so much for confirming that. Could you please provide me with a reference number for this call? That reference number is your proof. It is an official record in the insurance company system that you called on that date, spoke to a representative, and were told that this specific doctor at this specific practice was in network. Write that reference number down with the date and the representative's name. This is your third and most powerful piece of evidence. You have now built an ironclad case. Let's recap the triple check verification. 1. Digital recon. You log into your insurer's portal and screenshot the doctor's in-network status. 2. Human verification. You call the doctor's office with your specific plan name and get confirmation, along with the name of the person you spoke to. 3. Insurer confirmation. You call your insurance company with all the data you've collected and get a final confirmation, sealed with a call reference number. This entire process might take you 15 minutes, but those 15 minutes can literally save you from a $10,000 bill. You've created a paper trail. If the insurance company ever comes back and denies the claim, saying the doctor was out of network, you don't just have to panic and pay. You can appeal, and you have the ammunition to win. You can say, actually, on August 15th, I checked your own website, which I have a screenshot of. I then spoke to Brenda at the doctor's office. And most importantly, I spoke to your representative David at 2:15 p.m., and he confirmed the doctor was in network. My call reference number is 9-8-7 Alpha Lu 6. The game completely changes. You are no longer a victim of the system. You are an empowered navigator who has the receipts. Now, a quick word on a particularly nasty trap: hospitals and surgeries. Even if your surgeon is in network and the hospital is in network, the anesthesiologist who puts you to sleep, or the radiologist who reads your x-ray, or the pathologist who studies a tissue sample might be an independent contractor who is out of network. It's a cruel bait-and-switch built into the system. While the No Surprises Act has helped protect patients in emergency situations, for planned procedures, you must be your own advocate. You have to ask your surgeon's office beforehand. Can you confirm that every professional who will be involved in my care, including the anesthesiology group and the pathology lab, is in network with my plan? Get that confirmation in writing if you can. Okay, so you found the perfect in-network doctor. You're protected from surprise bills. But now you have to actually pay for the care. This is where the real game begins. The game of deductibles, copayments, and coinsurance. It's a confusing maze of numbers designed to trip you up. But in the next part, we're going to give you the map to navigate it like a pro. Alright, let's pull back the curtain on these three confusing terms. Think of them not as financial jargon, but as three different toll booths you have to pass through on the highway of healthcare. Each one collects money in a slightly different way. The first and biggest toll booth is the deductible. The deductible is the amount of money you must pay out of your own pocket for medical services before your insurance company starts to pay for anything significant. It's the first boss you have to defeat in the video game of American healthcare. Imagine you have a giant empty bucket at the beginning of each year. This is your deductible bucket. If your family plan has a $5,000 deductible, that bucket can hold $5,000 worth of medical bills. Every time you pay for a covered medical service, you're pouring money into that bucket. The doctor's visit, the lab test, the x-ray for your son's sprained ankle. It all goes into the bucket. You pay and you pay and you pay, filling it up. Your insurance company, they're just watching from the sidelines, waiting. They don't open their wallet until that bucket is completely full. Once you have paid $5,000, once that bucket overflows, then your insurance company finally steps onto the field and starts sharing the costs with you in a major way. Let's make this real. Meet the Miller family. They have a plan with a $5,000 family deductible. In March, their daughter, Chloe, gets a nasty ear infection that requires a visit to an urgent care clinic and some expensive antibiotics. The total bill comes to $400. The Millers pay that entire $400 themselves. They've now poured $400 into their $5,000 bucket. A few months later, Mr. Miller throws out his back playing softball. He needs an MRI. That bill is $2,000. Again, the Millers pay the whole thing. Now they've poured a total of $2,400 into their bucket. They're about halfway there. The insurance company still hasn't paid a dime. Then, in September, disaster strikes. Mrs. Miller needs an emergency appendectomy. The total cost of the surgery and hospital stay is a staggering $20,000. So what happens now? The Millers have already paid $2,400 this year. Their deductible is $5,000. So, for this $20,000 hospital bill, they are responsible for the remaining part of their deductible. They need to pour another $2,600 into the bucket to fill it up to the $5,000 line. They pay that $2,600. The bucket is now full. They have officially met their deductible. Now, and only now, does the insurance company step in to deal with the rest of that massive hospital bill. But there's a critical twist for families. Many plans have two types of deductibles: an individual deductible and a family deductible. This is a trap that snares millions of people. Let's say the Millers plan has a $2,500 individual deductible and a $5,000 family deductible. This means that no single person in the family will ever have to pay more than $2,500 towards the family deductible. In our example, when Mr. Miller hurt his back, his $2,000 MRI bill went towards both his individual deductible and the family deductible. If his bill had been $3,000, he would have paid the first $2,500, met his individual deductible, and then insurance would start sharing the cost for the remaining $500 of his care. But, and this is the important part, the family as a whole still hasn't met their $5,000 family deductible. The other family members would still have to pay for their own care out of pocket until the grand total paid by everyone in the family hits that $5,000 mark. The family deductible is the big one, the final boss. Once that's met, the insurance kicks in for everyone in the family for the rest of the year. Now, before you panic thinking you have to pay thousands just to see a doctor for a checkup, there's some good news. Thanks to the Affordable Care Act, many preventive services are covered at 100% before you meet your deductible. This includes things like your annual physical, flu shots, routine vaccinations for your kids, and certain cancer screenings. Your insurance company pays for these to keep you healthy and, frankly, to avoid paying for more expensive treatments down the road. So you can use your insurance without first emptying your bank account. Okay, so that's the first big toll booth, the deductible. What's the next one? It's called the copayment or copay. This is the easy one. A copay is a simple flat fee you pay for a specific service. It's the price of admission. Think of it like a ticket to a movie. You pay your $30 at the doctor's office front desk, and you get to see the doctor. You pay your $15 at the pharmacy counter, and you get your prescription. It's predictable. It's straightforward. A plan might have a $30 copay for a primary care visit, a $75 copay for seeing a specialist like a dermatologist, and a $250 copay for an emergency room visit. These amounts are fixed no matter what the actual cost of the service is. That $30 visit might have actually cost the insurance company $200, but your share is just that flat $30 copay. Here's the million-dollar question. Does that $30 copay count towards your giant $5,000 deductible bucket? The answer is maybe. It depends entirely on your specific plan. On some plans, every copay you make chips away at your deductible. On many others, they are two completely separate pots of money. You have your deductible bucket, and then you have this separate stream of copay fees. You have to pay your copays and meet your deductible. This is one of the most important details to check in the fine print of any plan you consider. Because if your copays don't count towards your deductible, you could end up spending a lot more out of pocket than you realize. So we've conquered the deductible. We understand the simple copay. Now we arrive at the third and final toll booth, coinsurance. If the deductible was the solo mission, coinsurance is the team-up phase. Coinsurance only kicks in after you have completely filled your deductible bucket. It's a percentage split. You pay a percentage of the bill, and your insurance company pays a much bigger percentage. The most common split is 80/20. This means that for any medical bill you get after your deductible is met, the insurance company pays 80%, and you pay 20%. Other common splits are 90/10 or 70/30. The key is you're no longer paying the whole bill. You have a powerful partner now. Let's go back to Mrs. Miller and her $20,000 appendectomy. We established that she and her family paid the remaining $2,600 of their deductible. That filled their $5,000 bucket for the year. But what about the rest of the bill? $20,000 minus the $2,600, they just paid leave $17,400. This is where coinsurance begins. Let's say their plan has an 80/20 coinsurance split. For that remaining $17,400 bill, the insurance company pays 80%. That's $13,920. The Millers are responsible for the other 20%, which is $3,480. So for that one hospital stay, the Millers paid $2,600 to meet their deductible, and then another $3,480 in coinsurance. That's over $6,000 out of their pocket for a single medical event, even with insurance. And for the rest of the year, for any other major medical expenses, they will continue to pay 20% of the cost. A $10,000 procedure would cost them $2,000. A $50,000 treatment plan would cost them $10,000. This leads to a terrifying thought. If you're paying 20% of every bill, what happens if you have a truly catastrophic medical event? A major car accident, a cancer diagnosis, a premature baby needing months in the NICU. The bills could run into the hundreds of thousands or even millions of dollars. Does your 20% share just keep growing forever? Could it bankrupt you? The answer, thankfully, is no. There is a safety net. There is a final ultimate shield that protects you and your family from financial ruin. It is arguably the single most important number on your entire health insurance plan, and it's the one we're breaking down next. This final shield is called the out-of-pocket maximum, or sometimes the out-of-pocket limit. And it is, without a doubt, the most important number for you to understand on your entire health insurance policy. It's the number that lets you sleep at night. It's the ceiling on your financial risk. It is the absolute final most you will pay for covered in-network medical services in a single plan year. After you hit this number, your insurance company pays 100% of everything else. 100%. The bleeding stops. To really understand the power of this number, let's go back to the Miller family. Mark, Sarah, and their 2 kids, Leo and Mia. They have a family plan with a $5,000 family deductible and an out-of-pocket maximum of $15,000. For them, these are just numbers on a page. Abstract concepts. Until one Saturday afternoon, their daughter, Mia, is at a friend's birthday party at a trampoline park. She's having the time of her life, and then she takes a bad fall. A very bad fall. The call comes and Mark and Sarah's world grinds to a halt. They rush to the emergency room. The first bill comes from the ER itself. They pay their $250 ER copay right there. That $250 counts towards both their deductible and their out-of-pocket maximum. The doctors do some imaging and realize the injury is complex. It's a severe fracture in her leg that's going to require surgery. Mia is admitted to the hospital. Now the financial clock really starts ticking. The costs are no longer small, predictable copays. We're into the big stuff. The hospital stay, the surgeon's fee, the anesthesiologist, the physical therapy that will follow. The bills start to pile up. The first big bill arrives for the initial hospital stay and surgery. It's $20,000. Now, remember the Miller's $5,000 family deductible? They haven't used it yet this year. So, they are responsible for the first $5,000 of this bill. They write the check. It's painful, but they knew this was part of the deal. They have now officially met their family deductible. But the bill was for $20,000. They paid $5,000. What happens to the other $15,000? This is where coinsurance kicks in. Their plan has an 80-20 coinsurance split. This means the insurance company pays 80% and the Millers pay 20%. So, on that remaining $15,000, the insurance company pays $12,000. The Millers are responsible for 20%, which is $3,000. So they write another check. For this one event, they've already paid their $5,000 deductible plus $3,000 in coinsurance. That's $8,000 out of their pocket. And it's not over. Mia needs follow-up appointments with the orthopedic surgeon. She needs weeks of physical therapy. Each visit, each procedure generates a new bill. And on every single one, the Millers have to pay their 20% coinsurance. Another bill comes for a follow-up MRI. It's $2,000. The insurance pays $1,600. The Millers owe $400. Another bill comes for the first month of physical therapy. It's $3,000. The insurance pays $2,400. The Millers owe $600. You can see how this feels. It's a relentless flood of bills. Every time the mail arrives, their hearts sink. They're adding it all up. $8,000 plus $400 plus $600. They're at $9,000 and they know more bills are coming. Feels like it will never end. They start to get scared. What if there are complications? What if she needs another surgery? How can they possibly afford 20% of potentially hundreds of thousands of dollars in medical care? This is the exact moment of terror that health insurance is supposed to prevent. And it does, because they keep paying. They pay their 20% of the next bill and the next. They pay for the specialized crutches. They pay for the medications. Their total out-of-pocket spending for Mia's care climbs. $10,000, $12,000, $14,000. Then, a final bill for a complex series of physical therapy sessions arrives. Their 20% share is $1,500. They look at their running total. They have paid exactly $14,000 so far this year. They pay this new bill. And at that moment, they have officially spent $15,500 out of their own pocket. But wait, their out-of-pocket maximum was $15,000. The moment they paid that bill, they crossed the threshold. They have hit their family out-of-pocket maximum for the year. And now everything changes. A letter arrives from their insurance company. It says they have satisfied their maximum cost-sharing responsibility for the plan year. For the rest of the year, whether that's 6 months or 6 days, for any covered in-network medical care for anyone in their family, the insurance company now pays 100%. The Millers pay nothing. 0. Mia needs another month of physical therapy? Covered at 100%. Mark sprains his ankle playing basketball a month later and needs to see a specialist? Covered at 100%. Sarah gets the flu and needs to go to the doctor? Her copay is waived. It's covered at 100%. The financial bleeding has completely stopped. They are shielded from any further costs for the rest of the year. That is the power of the out-of-pocket maximum. It transforms an infinite, terrifying risk into a finite, manageable number. Now there's a critical detail here that confuses a lot of people. The difference between an individual out-of-pocket max and a family out-of-pocket max. Most family plans have both. Let's use the Miller's plan as an example. It might have a family out-of-pocket max of $15,000, but an individual out-of-pocket max of, say, $7,500. This works like a two-stage safety net. If one person, like Mia, has a major medical event, her family will pay her copays, her deductible, and her coinsurance. Once the total they've paid just for Mia's care hits her individual limit of $7,500, the insurance company starts paying 100% of Mia's bills for the rest of the year. Her financial responsibility is done. However, the rest of the family, Mark, Sarah, and Leo, are not done. If Mark gets sick, he still has to pay his own copays and coinsurance. The family is still on the hook for their costs, because the family total hasn't hit $15,000 yet. The family out-of-pocket maximum is the master shield. It's triggered when the combined out-of-pocket spending for everyone in the family reaches that higher number. So in our story, Mia's costs hit $7,500. Her bills are now covered 100%. Then, let's say Mark needs a minor surgery that costs them another $7,500 out of pocket. At that point, the family's combined spending has hit $15,000. Bam! The family maximum is triggered, and now everyone, Mark, Sarah, Leo, and Mia, is covered at 100% for the rest of the year. This is why understanding both numbers is key. You need to know when an individual is protected, and when the entire family is protected. But here's the most important practical piece of advice I can give you about this. You have to know what counts and what doesn't count toward that magical number. What counts is simple: your deductible payments, your copays, and your coinsurance payments. That's it. But they only count if they are for covered medical services that you get from doctors and hospitals inside your plan's network. What does not count is even more important to know. First, and most importantly, your monthly premiums do not count. You could have a $15,000 out-of-pocket max and pay $800 a month in premiums. Even after you hit your max, you still have to pay that $800 every single month. Premiums are the cost of keeping the plan active. They are completely separate from the costs of your care. Second, anything your plan doesn't cover doesn't count. If you decide to get cosmetic surgery, for example, the cost of that will not count towards your out-of-pocket max. Third, and this is the big one, costs from out-of-network providers generally do not count. If your out-of-pocket max is $15,000 and you accidentally go to an out-of-network hospital that charges you $100,000, you are on the hook for that $100,000. Hitting your in-network max does absolutely nothing to protect you from out-of-network bills. It is a separate financial universe with its own, often much higher deductibles and maximums, or in some cases no maximum at all. This makes your out-of-pocket maximum a conditional shield. It is an incredibly powerful form of protection, but it only works if you stay within the castle walls, within the defined boundaries set by your insurance company. If you step outside those walls, that shield can vanish in an instant. Understanding those walls, understanding your network, is arguably just as important as understanding your costs, because choosing the right doctor can be the difference between a bill that's covered 100% and a bill that could lead to bankruptcy. It's a world of PPOs, HMOs, EPOs, and POS plans. And navigating that alphabet soup is exactly what we're breaking down next. Alright, let's demystify this alphabet soup, because these four letters, PPO, HMO, EPO, and POS, are the fundamental blueprints for how you and your family will get medical care. Think of them less as confusing acronyms and more as four different rulebooks for the same game. Each one has a different strategy for balancing cost and freedom. Your job is to pick the rulebook that works best for your team. Let's start with the most structured of them all: the HMO, which stands for Health Maintenance Organization. The best way to think of an HMO is like a private, all-inclusive club. To get in, you pay your membership fee, your premium, which is often lower than other plans. Inside this club, everything is designed to be efficient and coordinated, but there are strict rules. The most important rule is the gatekeeper. In an HMO, you are required to choose a primary care physician or PCP from within their network. This doctor is your quarterback. They are your first point of contact for everything that isn't a life or death emergency. Got a persistent cough? You see your PCP. Your son twisted his ankle playing soccer? You see your PCP. You can't just decide one day that you want to see a heart specialist. You must go through your PCP first. They will evaluate you, and if they agree you need a specialist, they will give you a referral. And that referral will only be for a specialist who is also inside the HMO's exclusive network. This is the key trade-off of an HMO. You get lower costs and the benefit of having one doctor who understands your entire health history, coordinating all your care. But you give up freedom. If you decide to go see a doctor outside the network, or you see a specialist without getting that golden ticket, the referral, the HMO will generally pay nothing. Zero. You are on the hook for 100% of that bill. The only exception is a true dire emergency. So if you live in an area with a strong HMO network of doctors and hospitals you like, and you're comfortable with your PCP being the central hub for your family's care, an HMO can be an incredibly cost-effective option. Now let's swing to the complete opposite end of the spectrum, the PPO, or Preferred Provider Organization. If an HMO is a structured private club, a PPO is an open-world adventure. Its core philosophy is freedom and choice. This is the plan for people who want to be in the driver's seat of their own healthcare. With a PPO, there is no gatekeeper. You do not need to choose a primary care physician. You don't need a referral to see a specialist. If your back hurts and you think you need to see an orthopedic surgeon, you can just pick up the phone and make an appointment with one. It's that simple. The PPO has a huge network of preferred doctors and hospitals, and as long as you stay within that network, you'll get the best rates, usually paying a simple copay or coinsurance. But here's the PPO's superpower. You are allowed to go outside the network. Let's say the top-rated child psychologist in your state isn't in your PPO's network. With an HMO, you'd be out of luck. With a PPO, you can still take your child to see them. Now it will cost you more. You'll likely have a separate, much higher deductible for out-of-network care. And instead of the insurance company paying the doctor directly, you might have to pay the full cost up front and then submit a claim for reimbursement. The insurance company will then pay a smaller percentage of the bill than they would for an in-network doctor. It's more work and more money, but the choice is yours. This flexibility comes at a price. PPO plans almost always have higher monthly premiums than HMOs. Your deductibles and copays might be higher too. You're paying for that freedom. A PPO is often a great fit for families who want direct access to specialists, have a specific doctor they want to continue seeing who might not be in other networks, or who travel often and want the peace of mind of having some level of coverage anywhere in the country. So we have the strict, cost-effective HMO and the flexible, expensive PPO. What if you want something in between? That's where the hybrids come in. First, let's look at the EPO, the Exclusive Provider Organization. An EPO is like an HMO's more laid-back cousin. It takes the two biggest features from the HMO and the PPO and mashes them together. From the HMO, it takes the strict exclusive network. With an EPO, you must stay in network for your care to be covered. Just like an HMO, there is generally no coverage for going out of network except for true emergencies. But from the PPO, it takes the freedom from referrals. With an EPO, you do not need a primary care physician to act as a gatekeeper. If your daughter needs to see an allergist, you can look up an in-network allergist and make an appointment directly. No referral needed. So an EPO gives you the freedom to manage your own care and see specialists directly, but it keeps costs lower by limiting you to a specific network of doctors and hospitals. It's a middle ground. You get more freedom than an HMO, but you'll likely pay a lower premium than a PPO. The catch? You have to be absolutely sure that the doctors and hospitals you want for your family are all inside that exclusive network. If they are, an EPO can be a fantastic value. If they aren't, the plan is useless to you. Finally, we have the rarest of the bunch, the POS or Point of Service Plan. A POS plan is the ultimate chameleon. It tries to be an HMO and a PPO at the very same time. How it behaves depends on the point of service, meaning it depends on the choices you make each time you need care. Like an HMO, a POS plan usually requires you to select a primary care physician. And for the lowest costs, you'll want to operate like you're in an HMO. Get a referral from your PCP to see other in-network specialists. If you follow these rules and stay in network, your costs will be very low, similar to an HMO. However, the POS plan also gives you the PPO-style option to go out of network. If you decide to see a specialist without a referral, or see a doctor who is outside the network, the POS plan will cover a portion of the bill. But just like a PPO, you'll face a higher deductible and a lower coverage percentage. You'll also likely have to handle the claims paperwork yourself. POS plans can be the most complex because you're constantly deciding which set of rules to follow. Do you go through your PCP for a referral to save money? Or do you bypass them and go straight to a specialist knowing it will cost you more? Because of this complexity, they've become less common. They offer a blend of features, but you have to be a savvy consumer to get the most out of them. So let's recap the rule books. The HMO is the walled garden, affordable and coordinated, but you must follow the rules and stay inside. The PPO is the open world. Go anywhere and see anyone, but freedom has a higher price tag. The EPO is the no gatekeeper garden. You can roam freely within the walls without a referral, but you still can't leave the garden. And the POS is the chameleon. It acts like an HMO when you're in network and a PPO when you go out. Understanding these four structures is the first giant leap toward choosing the right plan. It's not about which one is best. It's about which one's rules best match your family's life, your budget, and your healthcare priorities. But knowing the type of plan is only half the battle, because inside each of these plans is a whole different set of financial terms that determine what you actually pay when you walk into that doctor's office. We're talking about the real money, the deductibles, the copays, the coinsurance, and the all-important out-of-pocket maximum. And cracking that code is the key to truly understanding the cost of your care. Let's pull back the curtain on these four critical terms. Think of them not as confusing insurance jargon, but as four stages of a journey you and your family take every single year. Your goal is to get from the starting line to the finish line, where your insurance company provides a powerful safety net. Let's imagine a family, the Johnsons, a mom, a dad, and their energetic 8-year-old son, Leo. They just signed up for a new family health plan. The very first stage of their journey is a giant wall called the deductible. Their family deductible is $6,000. This is the amount of money the Johnsons have to pay out of their own pocket for medical care before their insurance company will pay a single penny for most major services. And listen closely, because this is the part that trips everyone up. The monthly premium they pay just to have the insurance does not count toward this deductible. That's just the price of admission to the game. So, one Saturday, Leo is climbing a tree, falls, and breaks his arm. It's a bad break. They rush to the emergency room. There's the ER visit fee, the x-rays, the orthopedic specialist who sets the bone, the cast. A few weeks later, the bills start rolling in. The grand total comes to $4,000. Who pays that $4,000? The Johnsons do. Every last cent. It's a painful, unexpected expense. But in paying it, they've chipped away $4,000 from their $6,000 deductible. They now only have $2,000 left to go before they've officially climbed over that wall for the year. Once you conquer the deductible, you enter the second stage of the journey. This is the land of cost sharing. Your insurance company finally wakes up and joins you on the path, but they don't carry you completely. You walk together. This is where two other terms come into play: copays and coinsurance. Let's start with the easy one, the copay. A copay is a simple flat fee you pay for a specific service. It's predictable. For example, the Johnsons plan might have a $30 copay for a regular doctor's visit or a $15 copay for a generic prescription. It's a small fixed amount you pay at the front desk. On many plans, these simple copays are available right from day one, even before you've met your big deductible, which is a nice perk for routine care. But for the bigger, more complicated stuff, the things that happen after you've met your deductible, you'll most likely face coinsurance. If a copay is a flat fee, coinsurance is a percentage. It's right there in the name, coinsurance. You and the insurance company are now partners in paying the bill. A common coinsurance split is 80/20. This means that after your deductible is met, the insurance company pays 80% of the cost, and you pay 20%. Let's go back to the Johnsons. A month after Leo's arm has healed, his mom, Sarah, starts having persistent stomach pains. After a visit to her doctor, a $30 copay, she's referred for a series of expensive diagnostic tests, including an MRI. The total bill for these tests is a whopping $10,000. Now let's do the math. The Johnsons have already paid $4,000 this year for Leo's arm. Their family deductible is $6,000. So for this new $10,000 bill, they first have to pay the remaining $2,000 of their deductible. Boom! The deductible is now met. They've officially climbed the wall. Now what about the rest of that bill? The total was $10,000. They paid $2,000 to meet the deductible, so there's $8,000 left. This is where their 80/20 coinsurance kicks in. The insurance company pays 80% of that $8,000, which is $6,400. The Johnsons are responsible for the other 20%, which is $1,600. So for Sarah's tests, their immediate out-of-pocket cost was $2,000 for the rest of the deductible, plus $1,600 for their share of the coinsurance. That's a total of $3,600. At this point, the Johnsons are probably feeling stressed. So far this year, They've spent $4,000 on Leo's arm and another $3,600 on Sarah's tests. That's $7,600 out of their savings. Feels like the costs will never end. But this brings us to the fourth and final stage of the journey, the most important number on your entire insurance plan: the out-of-pocket maximum. This is your financial superhero, your absolute safety net. The out-of-pocket maximum is the most you will ever have to pay for covered in-network medical services in a single year. Once you hit this number by paying your deductible, copays, and coinsurance, your insurance company steps in and pays 100% of everything for the rest of the plan year. You pay nothing. Let's say the Johnsons family out-of-pocket maximum is $10,000. This is their finish line. So far, they've paid $7,600 towards it. They are getting close. Then the unthinkable happens. The dad, Mike, is in a minor car accident and needs physical therapy for a few months to recover. The total cost of his physical therapy is projected to be $12,000. Normally, with his 80/20 coinsurance, Mike would be on the hook for 20% of that $12,000, which is $2,400. But wait, remember their out-of-pocket maximum? It's $10,000, and they've already paid $7,600 this year. So, how much do they actually have to pay for Mike's physical therapy? They only have to pay the difference between what they've already spent and their maximum. $10,000 minus $7,600 is $2,400. So, Mike starts his physical therapy. The Johnsons pay the first $2,400 of the bill. And at that exact moment, bells go off, confetti falls from the sky, metaphorically speaking, because they have officially hit their $10,000 out-of-pocket maximum for the year. They are done. For the remaining $9,600 of Mike's physical therapy, who pays? The insurance company. 100% of it. If anyone in the family needs another surgery, another hospital stay, any covered medical care for the rest of the year, who pays? The insurance company. 100%. The Johnsons can now get the care they need without the fear of financial ruin. They have reached the safety net. So let's recap that journey. The deductible is the big wall you have to climb alone. Coinsurance is the path you walk together with your insurer after the wall. And the out-of-pocket maximum is the finish line. The absolute cap that protects your family from a catastrophic financial event. Understanding this flow is everything. A plan with a super low monthly premium might look tempting, but if it has a $15,000 family deductible and a $20,000 out-of-pocket max, one bad accident could completely derail your finances. Conversely, a plan with a higher monthly premium might have a much lower deductible and max, giving you more predictability and peace of mind. You have to know what kind of financial risk you're willing and able to take on, and that risk is defined by these four numbers. Now that you understand the fundamental mechanics of how you pay for care, we can finally talk about the different types of arenas you can play in. We're talking about the alphabet soup of health insurance: HMO, PPO, EPO, and HDHP. Each one uses these same core concepts: deductibles, coinsurance, but they apply them in very different ways with different rules about which doctors you can see and when. So let's break down this alphabet soup, starting with the most structured of them all, the HMO, or Health Maintenance Organization. Think of an HMO as a well-organized but walled garden. It's designed to be efficient and keep costs down by carefully managing or maintaining your health. The absolute central figure in an HMO is your primary care physician, or PCP. You must choose one from a list within the HMO's network. This doctor is your gatekeeper. They are your first call for everything that isn't a life-threatening emergency. Got a weird rash? Call your PCP. Your knee has been aching? Call your PCP. You can't just decide one day to go see a heart specialist. You have to go to your PCP first, and they have to give you an official referral to that specialist. And here's the biggest rule of the HMO. You must stay inside the network. The doctors, the hospitals, the labs, they all have to be part of the HMO's exclusive club. If you go to an out-of-network doctor for a non-emergency, the HMO will likely pay zero. Nothing. You're on the hook for the entire bill. Now, this sounds incredibly restrictive, and it can be, but there's a reason people choose HMOs. In exchange for giving up that freedom, you typically get the lowest monthly premiums and lower out-of-pocket costs like copays. The whole system is designed for coordinated care. Your PCP knows your entire health history and, in theory, can make sure you're getting the right care from the right specialists without duplicating tests or treatments. It's a great fit for families who are happy with the doctors in the network, don't mind the referral process, and want predictable, lower costs. But what if you hate the idea of a gatekeeper? What if you want to see any doctor you choose whenever you want? Then you're probably looking for a PPO or a preferred provider organization. The PPO is all about flexibility and choice. It's the polar opposite of the HMO's walled garden. With a PPO, you don't need a primary care physician. You don't need referrals. If you wake up and decide you want a second opinion from a top dermatologist across town, you just pick up the phone and make an appointment. The PPO has a large network of preferred doctors and hospitals, and as long as you stay within that network, you get the best rates. You'll pay your normal copay or coinsurance after your deductible. But the real magic of the PPO is that the walls are gone. You can go out of network. Let's say your sister recommends a fantastic pediatrician for your kids, but she's not in your PPO's network. You can still take your kids to see her. The catch? It's going to cost you more. A lot more. Your insurance will still pay a portion of the bill, but you'll face a separate, much higher out-of-network deductible and a lower coinsurance percentage. For example, your insurance might cover 80% of an in-network visit, but only 50% of an out-of-network one. This freedom comes at a price. PPO plans almost always have the highest monthly premiums. You're paying extra for that choice and flexibility, whether you end up using it or not. It's ideal for families who value direct access to specialists or have specific doctors they want to see who might not be in a more restrictive network. So we have the restrictive but cheap HMO, and the flexible but expensive PPO. What if you want something in between? That's where the EPO comes in. An exclusive provider organization. An EPO is a hybrid. It takes one key feature from the HMO and one from the PPO. From the PPO, it takes the freedom. With most EPOs, you don't need a primary care physician, and you don't need referrals to see specialists. You have direct access. From the HMO, it takes the network rule. You have to stay within the EPO's exclusive network of providers. There is generally no coverage for out-of-network care, except in a true life or death emergency. It's like a PPO with a hard border. You have all the freedom you want as long as you stay within the lines. If you step out, you're on your own. Because of this restriction, EPO premiums are usually lower than a PPO's, but a bit higher than an HMO's. It's a middle ground option for people who want the convenience of not needing referrals, but are confident they can find all the care they need within a specific network. Okay, so those are the three main network types: HMO, PPO, and EPO. But there's one more acronym that's become incredibly popular, and it's a bit different. It's the HDHP, or High Deductible Health Plan. An HDHP isn't really a network type on its own. You can have a PPO-based HDHP or an HMO-based HDHP. The HDHP part refers to the financial structure of the plan, and it's exactly what it sounds like, a plan with a very, very high deductible. We're talking thousands of dollars for an individual, and potentially over $10,000 for a family that you have to pay out of pocket before the main insurance benefits kick in. Hearing that, you might think, why on earth would anyone sign up for that? Two reasons. First, the monthly premiums are often dramatically lower than any other type of plan. But the second and most important reason is the secret weapon that comes with it, the HSA or Health Savings Account. An HSA is a special savings account that you can only get if you have a qualified HDHP, and it is, without a doubt, one of a family's most powerful financial tools. It's like a 401k for your healthcare, but even better. It has a triple tax advantage. First, the money you put into your HSA is tax deductible. If you contribute $5,000, you get to deduct that $5,000 from your taxable income for the year. Second, that money can be invested in stocks and mutual funds, and it grows completely tax-free. And third, when you take money out to pay for qualified medical expenses, anything from doctor visits and prescriptions to dental work and eyeglasses, that withdrawal is also 100% tax-free. There is no other account in the U.S. tax code that gives you a tax break on the way in, a tax break while it grows, and a tax break on the way out. The money is yours. It's not use it or lose it like an FSA. It rolls over year after year for the rest of your life. If you switch jobs, you take your HSA with you. Many employers will even contribute money into your HSA for you. That's free money. The idea is this: you pay the low premium for the HDHP. Then you take the money you're saving on premiums and put it into your HSA. You use that tax-free money to pay for your routine medical costs until you meet that big deductible. If you have a healthy year, that money stays in your account, growing and compounding for the future. It becomes a safety net for a major medical event down the road, or even a retirement account. After age 65, you can withdraw money from your HSA for any reason at all, and it's just treated like a traditional 401k. An HDHP with an HSA is a fantastic option for families that are relatively healthy, don't expect a lot of medical bills, and are disciplined enough to save and invest the difference in premiums. It puts you in the driver's seat of your healthcare spending. However, it also carries risk. If someone in your family has a sudden, expensive medical emergency early in the year before you've had a chance to build up your HSA, you are on the hook for that entire high deductible out of your own pocket. It requires you to be an active, price-conscious consumer of healthcare, which can be a burden. So, choosing between these plans isn't just about the numbers. It's about your family's health, your tolerance for risk, and how you prefer to access care. Do you want a managed, predictable system? Or do you want total freedom even if it costs more? Or are you willing to take on more risk up front for the potential of incredible long-term, tax-free savings? That choice right there is the final boss of picking a health plan. And now that you understand the mechanics of each one, you're equipped to make that decision. But there's one more piece of the puzzle, and it's arguably the most important. When and where can you actually do this? You can't just wake up on a Tuesday in April and decide to switch insurance plans. The system is built around a single critical period of time. This is called open enrollment. Think of it like the one time a year the massive complicated gates to the health insurance kingdom swing open for everyone. For most people with employer-sponsored insurance, this is a 2 to 4 week period in the fall, usually October or November. For those buying their own insurance on the government marketplace, it typically runs from November 1st to January 15th. During this window, and only this window, you can enroll in a new plan, switch from your current plan to a different one, or drop your coverage entirely. This is your moment. It's the time to take everything we've talked about, your family's health needs, your budget, your risk tolerance, and put it into action. Missing open enrollment is like missing the last train out of town. If you don't make a choice, you're often automatically re-enrolled in your current plan for better or worse. Or if you don't have a plan, you could be locked out of getting one for an entire year. The stakes are incredibly high. So, what happens if something major changes in your life outside of this narrow window? What if you get married in June? Or have a baby in March? Or lose your job in August? Does the system just say, "Too bad, see you in November"? Thankfully, no. This is where a crucial exception comes into play. The qualifying life event, or QLE. A qualifying life event is a change in your situation that allows you to make changes to your health insurance outside of the open enrollment period. It cracks open a special enrollment period, usually lasting 60 days from the date of the event, giving you a chance to adapt your coverage to your new reality. The most common QLEs are what you'd expect. Losing your existing health coverage, which most often happens when you leave a job. Getting married is another big one. You can join your spouse's plan or get a new family plan together. Having a baby, adopting a child, or placing a child in foster care is a massive QLE, allowing you to add your new dependent to your plan. And a permanent move to a new zip code or county can also qualify, especially if your old plan doesn't offer coverage in your new area. This is the system's safety valve. It recognizes that life doesn't operate on a corporate calendar. The birth of a child doesn't wait for November. A dream job offer won't pause until open enrollment begins. The QLE ensures you're not left unprotected because life, well, happened. Now let's talk about the biggest, most common, and often most stressful QLE of all, losing your job. For millions of Americans, our health insurance is tied directly to our employer. So what happens the day that tie is severed? You walk out of the office for the last time, and suddenly your family's health safety net is gone. It's a terrifying thought. This is where a law called COBRA comes in. COBRA stands for the Consolidated Omnibus Budget Reconciliation Act, which is a mouthful, so everyone just calls it COBRA. It's a federal law that gives you the right to continue your exact same employer-sponsored health coverage for a limited time after leaving your job, typically for up to 18 months. This sounds amazing, right? You get to keep your doctors, your plan, your network. There's no disruption. But here's the catch, and it is a massive one. When you were employed, your company likely paid a significant portion of your monthly health insurance premium. They might have been paying 70, 80, even 90% of the total cost as part of your benefits package. Under COBRA, you are now responsible for 100% of that premium, plus a small administrative fee. Let that sink in. If your total family plan premium was, say, $1,800 a month, and your employer was paying $1,400 of that, you were only seeing a $400 deduction from your paycheck. Now, on COBRA, you have to write a check for the full $1,800 every single month. And you have to do this at the exact moment you've lost your primary source of income. It can be a brutal financial shock. Cobra is a fantastic safety net, ensuring continuity of care, but it is an expensive one. It's a lifeline, but it's a lifeline you have to pay for in full. So if Cobra is too expensive, what's the alternative? This brings us to the final major piece of the American healthcare puzzle, the health insurance marketplace. You've probably heard of it as Obamacare or the ACA, which stands for the Affordable Care Act. The marketplace, which you can find at healthcare.gov, is a government-run service where individuals and families can shop for and compare health insurance plans in their area. This is the primary option for people who are self-employed, work for a small business that doesn't offer health benefits, or who have lost their job and find a Cobra plan unaffordable. The plans on the marketplace are offered by private insurance companies, the same Blue Cross, United Healthcare, Aetnas, and Cignas of the world. But they have to meet certain standards set by the ACA, like covering essential health benefits and not denying coverage for pre-existing conditions. But the single most important feature of the marketplace is financial assistance. Based on your income and family size, you may qualify for subsidies that can dramatically lower your monthly premiums. This is called the premium tax credit. It's the government literally helping you pay your monthly insurance bill. For a family of 4, depending on their income, these subsidies can slash the monthly cost from over $1,000 down to just a few hundred, or in some cases even less. This is why, if you lose your job, you must compare the cost of Cobra against the cost of a plan on the marketplace. Cobra gives you continuity. The marketplace, for many families, gives you affordability. It's a critical calculation to make during a stressful time. There is one other option you might see advertised: short-term health insurance. Be very, very careful here. These plans are cheap for a reason. They are not ACA compliant. This means they are not required to cover essential health benefits. They can, and often do, deny coverage for pre-existing conditions. They can have annual and lifetime coverage limits. They are truly meant as a temporary bridge for a month or two, say between one job starting and another. They are not a substitute for real, comprehensive health insurance, and can leave your family exposed to catastrophic financial risk. So we've done it. We've gone from the most basic concepts of premiums and deductibles to the complex machinery of plan types, savings accounts, and enrollment periods. We've covered what feels like a lifetime of financial education in one sitting. The question is, what do you do with all of this information? How do you distill it down into a simple, actionable plan for your family? Let's create one right now. A final checklist. Step 1. Identify your window. Is it open enrollment season? Or have you experienced a qualifying life event? This determines when you can act. Step 2. Assess your family's real-world health needs. Look back at the last year. How many doctor visits? Any prescriptions? Any AR trips? Now look forward. Are you planning on having a child? Does someone need braces? Is a surgery on the horizon? Be honest and thorough. Step 3. Define your budget. What can you comfortably afford for a monthly premium? And, just as importantly, how much cash could you access if a true emergency happened and you had to pay your full out-of-pocket maximum? This premium versus max calculation is the core financial trade-off. Step 4. Compare the plan structures. Based on your needs and budget, does the predictable managed care world of an HMO make sense? Or does the freedom and flexibility of a PPO justify the higher cost? Or are you a candidate for the long-term tax-advantaged savings power of an HDHP paired with an HSA? Step 5. Check the networks. Before you fall in love with any plan, use the insurance company's online tools to verify that your family's trusted pediatrician, your primary care doctor, your specialist, and your preferred hospital are all in network. This step is non-negotiable. Step 6. Do the final math. Don't just look at the premium. Add the premium to the out-of-pocket maximum to understand your true worst-case scenario costs for the year. Sometimes a plan with a slightly higher premium, but a much lower deductible and max is the smarter financial choice for a family. And finally, step 7. Explore all your options. If you have employer coverage, analyze it. But also go to healthcare.gov. You might be surprised to find that a marketplace plan with subsidies is a better deal for your family. Never assume. Always compare. You now have the framework. You have the vocabulary. You have the knowledge to navigate one of the most complex and important decisions you will ever make for your family. This isn't just about avoiding medical debt. It's about buying peace of mind. It's about knowing that if the unthinkable happens, a sudden illness, a serious accident, Your family's financial future is secure. You have a shield. You are no longer just a passenger in this system. You are the pilot. You can now read the dials, understand the controls, and confidently choose the best path forward for you and the people you love. You have the tools. You have the guide. Now go build your family's fortress of financial and physical well-being. You can do this.